So first of all, you enter the station and then you show the examiner your number, and the examiner approves it and then start the station. So what are you going to do?
Wash hands.
Okay, you wash your hands, very important. Of course, you don't
Introduce
wash your
yourself,
hands with soap and
check
water.
the patient.
Go on.
Introduce yourself, check the patient's details, check the consent, make sure I have my equipment.
Before we go to the
Other things I
equipment,
need.
so I'm going to stop you
Explain.
briefly. That's correct. So first of all, wash your hands. Wash your hands. Some of you may misunderstand it's soap and water. No, it's not with soap and water. It's just gelling your hands. And you do that immediately after showing your number to the examiner because it takes time for the hands to dry. So before you wear gloves, you need to have a bit of time between washing your hands and wearing the gloves, because all of you would know it will be a nightmare to wear the gloves with a wet hand. So wash your hands, enter the station, and then start talking to the patient. Introduce yourself. How would you introduce yourself to the patient?
I'm Dr. Prasad, one of surgical doctor.
Very good. That will be the end of it. Always use surgical doctor. That's my favorite word, because regardless of whether you're a consultant, you're an SHO, you're a registrar, surgical doctors will cover that, encompass everything. It's an umbrella term. Whenever you're talking to the patient or the patient's family, just use the word I'm surgical. I'm one of the surgical doctors. And I would always use my first name. Again, that makes things that usually breaks down the barrier, communication barrier between yourself and the patient as well. So, hi, I'm Yet. I'm one of the surgical doctors. May I confirm your name and age, please? Name and date of birth. If the patient is wearing a wristband, always check the wristband as well. Often the patient won't be wearing a wristband. Right. Next, explain about the procedure. How are we going to explain about the procedure?
Tell him that you have a abscess in your thigh and we're
No,
planning
collect.
give an incision and remove the collection. We will numb your skin so you won't feel any discomfort. If during this you have any discomfort, please let me know. Do you understand what I've just explained to you?
And then
Or do you have any
says, no,
questions?
doctor, I don't understand. What is the incision and the collection?
Okay, so I'm going to cut out. Okay,
I
I'm going
will
to explain.
drain the pus. I will drain the pus from your thigh. So that will involve me numbing the area. And please let me know. That will help you relieve your symptoms. So please let me know if you have pain during the procedure. Is that
So
okay?
that's correct. Very important thing for you to be aware is do not use any of the technical terms or any of the jargons, as if you're talking to a 5 years old child in a layman term. Right. That will be very, very important, because otherwise there are usually 4 communication marks and you might lose them. Right. So what you should say is, uh, um, I'm going to drain your abscess. You can use the abscess, by the way. Abscesses are termed as a layman term. I like to drain the abscess and open up the abscess and then drain it out and then relieve the symptoms. That is the simplest thing that you can do that. Is that all right? So would you need a written consent for this procedure?
Yes.
Yes.
Yes, and
Yes.
the answer is yes, but we don't have time. So the consent, what we're going to say is I'd like to
Verbal consent.
at the consent, check a consent. Usually in the candidate instructions, or the examiner this time steps in and say, okay, the consent's been taken. Assume the written consent's been taken. Then I'll ask for an assistant. I like to have an assistant. And again, this is a verbal checklist. So I like to do a WHO checklist. So we'll talk about WHO checklist in details in one of the knowledge stations. So I'm not going to go into that in detail. So this is the introduction part, and you should do it quickly within 15 minutes.
Am I just going to mention that I'm going to do the WHO checklist? I mean,
Yes.
because obviously we don't have time, right?
Yes.
Yeah.
So ask for an assistant, and just if the examiner, you have to ask for an assistant to the examiner, and the examiner will tell you, yes, I'll be assistant. That time I will just briefly verbalize that, okay, I'd like to do a WHO checklist. That's it. Next, equipment. You do not need to verbalize checking equipment. Just a quick glance is enough. But during your quick glance, make sure you've got sterile gloves, which you won't. In the exam, they won't give you sterile gloves. Usually they will ask you to do the examination gloves and assuming these are sterile gloves. But sometimes they will give you the sterile gloves. So depending on the situation, most of the time you'll end up doing with the examination gloves, right? The examiner will tell you, assuming these are sterile gloves. And then antiseptic solution, drape. If they're not haven't done the cleaning and draping, you have to do it yourself. But for the last pretty much 10 years or so, they haven't asked you to do the draping and cleaning anymore because they understand that even doing the procedure itself takes a bit of time. So candidates will not finish doing the procedure. That's why they removed the cleaning and the draping part. Local anesthetics. Most of the time, they don't ask you to give local anesthetics anymore. Again, pretty much the same reason. So candidates keep pricking themselves and worse, pricking the examiner, pricking the patient, and all these things. So they stopped doing the local anesthetics as well. Because once you've become sterile, who hold the anesthetic bottle? I mean the ampule. Who should hold the local anesthetic ampule?
Your assistant.
Your assistant, in this case, the examiner. That's how you step the examiner, right? You are shaky and then you end up stepping the examiner stuff. So they have pretty much removed these parts, but still, in certain situations, they will still ask you to do it. Right? Syringe and the needle, scalpel to do it, and then culture, swab, and the bottle to go the sample, to send the sample afterwards. The gauze, forceps, scissors, and the wound dressing afterwards, and the clinical waste bin. Usually they're all there. So very important thing, you do not need to verbalize these equipment list, but to have a quick glance of what you've been given. Usually on the side of the patient, there will be a tray, sterile tray prepared just for you, ready to go.
Will we have a sharps, like a sharps container separately? Do we have to
Yes.
get rid of sharps separately?
Yes.
Okay.
So that is a very important thing as well. I'll mention it later on down the line. So clean and drape. But as I said, most of the time it's already cleaned and draped, so you don't need to do anything. Next, check local anesthesia. Very important because
It takes
what?
some time for the anesthetic to work, and you might.
So look at the system.
Yeah, because it's expired.
It's right.
Right.
Yeah.
99.9% of the local anesthetics that you will find in the exam are expired, and it's your duty to pick it up. Obviously, you don't want to waste the local anesthetics that's not expired in the exam. So most of the local anesthetics they will use in the exam are expired. How do you check local anesthesia?
By two persons, assistant and myself.
You have to check what that is. Well, in whatever you're going to give to the patient regarding injections or irrigations, in terms of the medical irrigations, medicine irrigations, or putting in a prosthesis, for example, vascular graft or a valve or a knee replacement, for example, a knee, what you have to check is two-person checks. One, you have to check what that is, and two,
Okay.
what is the expiry date. In this case, what that is would be most of the times the lidocaine, either 1% or 2% lidocaine, and the expiry date. And checking yourself is not enough. You have to check it with another person. That's why usually it's the scrub nurse who's going to check it with the circulating nurse. They'll come together and then check it. But if it's an important processes, they'll come to the head end, and then you would have seen they will check with the operating surgeon. Okay, this is the valve, this is the model, and this is the expiry date. I happy for you to open it. Obviously, because regarding the if you mistakenly open a wrong medication, you can throw it away. That's okay. But if you mistakenly open the valve, that's about $5,000. You can't just throw it away. But so that's why processes are very, very more important. Of course, that's why checking two-person, no exceptions. Very important, no exception. So you have to turn to the examiner and say, I'll let me check local anesthesia, and then you spell it out. Okay, this is 2% lidocaine, and the expiry date is this and this and that, and this is expired. And the examiner will tell you, okay, assuming it's not expired, please proceed. And then we'll ask the patient's allergy, any latex allergy, any of the allergies that I had before, and calculate the local anesthetic dosage. So how do you calculate the local anesthetic dosage?
Maximum
3%
dosage
Maximum
into
dose multiply
per kg, ml per kg. So it's 3 ml per kg for lignocaine, without adrenaline, and 7 ml with
with
adrenaline.
adrenaline.
So it's not ml per kg, by the way. It's a milligram per kilogram. That's why
Oh,
we
yeah.
have to calculate the dose.
My bad.
Otherwise, we can just give mil and then kilogram and then very simple. Right, there's a formula I want you to know. Most of the time, what we do, we try to sort out in our brain, but I want you to go systematically. So we'll go to the local anesthetic station, and then at the end, there is a formula. You may see this formula very complex things, but it's a very simple thing. You multiply three things. The first thing is the maximum allowable dose in milligram per kilogram. For the lidocaine, that's always 3 milligram. Next, second thing is the weight divided by 10. Again, it's a simple maths. If it's a weight is 70, then 7, 88. So let's say maximum allowable dose is 3. We've got 2%. The patient's got 70 kilograms. So 3 times 7,
21.
21. And the last part is 1 divided by percent of the concentration. So if it's 1%, 1 by 1 is 1%. If we've got, let's say, 2%, 1 divided by 2 is
0.5.
0.5. So 0.5 times 7 times 3. That would be
11.
21.
10.1. 10.5.
10.5. Right? Why? Because this is 3, 7 is 21. Half of 21 is 10.5. In short, 10.5. So this is fairly straightforward. And this is particularly important if you want to calculate with, let's say, bupivacaine. Because bupivacaine comes in with 0.25 or 0.75, then you're in trouble. Then you have to pretty much write it down and then start calculating things properly. So this is the formula that you need to know. And most of the time, you're going to see lidocaine only in the procedure stations. Multiply three things. One is maximum allowable dose. Next is the weight. And the third is the 1 divided by the percent of the local anesthetics. Let's go back to the session drainage. Incision and drainage. Okay.
So at what time we check local anesthesia after wearing the glove or before wearing the glove because of we
Before.
can't touch before.
Before, of course. So you have to prepare everything before you start the actual procedure. Once you start the actual procedure, you have to wear the sterile gloves and you can't touch the non-sterile things. So the worst thing is, let's say you presume to wear sterile gloves and you forgot to check the local anesthesia. What you can do is say that I like to check the local anesthesia and then change gloves. The examiner usually say, okay, assume that. Or you can ask the examiner to hold it for you and then check it together. But most of the time, the examiner won't be happy, right? If you ask them to do too much. So calculate the local anesthetic dosage, and then the next we're ready to start. Sharp's crutch is the warning shot that we give to the patients if the patients are going to experience any sharp thing. For example, in this case, injections, or you are cannulating the patient. So Sharp's crutch is enough to warn them. But don't need to say anything at all, just Sharp's crutch and then go in. Next, we are going to wait. Ideally, we need to wait 5 to 10 minutes for the local anesthesia to take maximum effect, but obviously we don't have time. So just verbalize it and then move on. Next, always make a habit of testing the sensation before you make an incision. How do you test the sensation?
By
Tooth force.
picking tooth forceps.
Or you can use the
Forceps.
actual tooth forceps and then test the sensation. Obviously, we're just pretending because what you're trying to do is everything is on the silicone pad. So afterwards, mount the blade in the needle holder, hemostats is required. Most of the time, they will use the single-use scalpel in the exam, so you don't need to do this anymore. But do you know how to mount the blade on the needle holder? Sorry, on the blade holder.
Yeah.
Yes.
Sorry, can you ask again?
Do you know how to mount the blade on the blade holder?
Yeah.
Yeah, you ask your assistant to open the package and you take a needle holder and you grab the blade with the needle holder from the inside, and then you hold this BP handle and you slide it on top of it while holding the needle holder without touching the blade.
Yeah. Very important thing is, one, do not touch the sharps with your own hand. It's a must, no. You may end up failing the station. because touching the sharps demonstrates to the examiner that you're not a very safe person. Right? That said, as long as you demonstrate you're a safe person, you will pass the exam quite comfortably. Never touch the sharps, including the blades. And when you're going to mount the blade, clip it, usually from the side, and then slowly slide it over the blade holder until you hear a click. If you want to remove it, you slightly flip it over and then push it out. Again, if you haven't done that, make sure you watch videos. Everything's on the YouTube, right? There are a lot of things on the YouTube. So please make sure you do that. Particularly, I'm mentioning about this one because this is not what we do normally. This is by the time we're ready to operate, this is what the scrub nurse do. So the scrub nurses, they will do it and then they'll hand you over the blade in a ready position. So make sure you know how to do that as well. Next, the make an incision. Always go for a single incision. And how would you determine the incisions? Let's say the pad is on the patient's thigh. The patient's lying 45 degrees on the bed. How are we going to do the incision?
Along the axis of the thigh.
Along the Langerhans lines.
Along the Langerhans lines. And Langerhans lines are usually along the axis of the limb. So along the axis of the thigh would be the correct answer. Do not do it across, right? Do it along the axis of the line. And then whatever comes out, we'll place it in a container and send it to the lab. Which lab are we talking about?
Microbiology.
Microbiology, culture, and
Oh, yeah.
sensitivity.
A sample is very, very important. If a sample is not obtainable, a swab is the second best option, but swabs are not that great because of the lots of contamination problems and such. But in this case, of course, it's less contamination. More contamination when you try to take the swab on the ward rather than the operating theater. Next, we're going to apply pressure to the surroundings to express the discharge. Make sure everything's come out initially. And the next, finger breakdown of the loculi. So usually you have to rub around something. Usually it goes to your finger and then try to break things down, the loculi and the compartmentalized abscesses. But break down the loculi. Should you use your finger?
Yes.
Yes, we do use our finger, but covered by gauze.
When should you not use the finger? I mean, not
By
use.
cut
I mean,
injuries and
trauma, when you expect bone fragments or
external.
something sharp and being there.
So the general rule is if it's a hole that you've made, you can use your finger. If it's a hole, it's already there before you see the patient, then you shouldn't put your finger at all. Right? So if that's the case, then you can use a small mosquito or a small clump, then rub around the gauze on top of the tip of the clump and clamp it, and then you can use that to break down the loculi as well. Next, irrigate the cavity with normal saline or 3% hydrogen peroxide, but usually there is none. The examiner will tell you, okay, assume it's there. And then afterwards, pack the wound. What do you pack the wound with?
sterile gauze.
Alginate or sterile gauze.
Usually sterile gauze, there is nothing much in the exam, right? Ribbon gauze, sterile gauze, or in reality, what do we use?
Alginate.
Usually
Alginate.
alternate dressings, right? You can just pack the alternate dressings that contain the silver as well. So that's a bit of antibacterial properties. Right, so often during when you're doing this procedure, the examiner will be asking you the questions and the patient will be asking the questions. Let's say you are trying to break down loculi and then the patient says, doctor, that's painful. What do you say?
I'm so sorry. Do you want me to stop or can I continue?
And
And I offer you a painkiller.
not painkiller. What do you offer?
Numbing agent. Numbing
Numbing
agent.
agent. A bit more numbing
Numbing.
agent. All right.
Okay.
So that's why do not use up all the local anesthetic. Again, you don't have to, most of the time you don't have to give it. But if you have to give it, always leave about a meal or two in case you have to give a bit more of the local anesthesia. So I'm sorry about it. Do you want me to stop? Or I'll give you a bit more numbing agent. And the patient usually say, no, it's okay, doctor, please continue. Nothing is coincidence in the exam. There is a specific instructions that the patients get it from the notes, and then whatever the reaction is, whatever their action is, the examiner is observing your reaction, meaning patient says, doctor, that's painful, and then the examiner is looking at you how you're going to respond. That's how you get the professionalism marked. So next, Doctor, I've got so during when you're doing the procedure, the patient will ask you, doctor, will it leave a scar?
Yes, there might be slight scarring.
But we'll try to minimize it as much as possible.
Can you minimize it?
Can't.
Not really.
Not.
Usually not really, because this is not the incision that you're making it. This is you're just opening up the abscess. And how abscesses heal?
The secondary intention.
Usually with
Secondary
a
intention.
secondary intention, except if the abscess is very deep. But the very deep ones, then what do we do?
Put a drain in.
Drainage.
Okay. But very deep ones, large deep ones.
Delayed suturing.
Percutaneous drainage.
Drainage may not be enough that time.
Secondary suture.
So we'll talk about the wound management in a minute later on. So that's the case. One of the things is the vac dressing we have to put, especially the deep white wounds. So you debride the wounds, you try to take out as much as you can, and then you put the vac dressing, which eventually be sucking it out. And once the wound becomes clean, the base is cleaned and okay, then you may proceed with closing the wound rather than the secondary healing and stuff. But the abscesses that we see, these are not very deep abscesses and they heal by secondary intention. And there's nothing we can do to minimize the scar. So you must be very, very, one, do not falsely reassure the patient. Do not say you won't have a scar. Secondly, you cannot, you must always be truthful with the patient to a certain extent. So what we're going to say here is, yes, there is going to be a scar, but hopefully it will not be a big one. That will be reassuring the patient. In a slightly separate scenario, let's say if you're doing the nevus excision, if you're doing the nevus excision, you have got 100% control over the incision line. Well, then you can say, yes, I'll try my best to minimize the scar so that it's become acceptable. Next question, patients will ask, okay, doctor, will I have pain after the procedure?
Yes. But I will
Will be
prescribe some medication after procedure to relieve your pain.
Again, you might have a bit of pain after the procedure, but don't worry. I will prescribe or will give you some pain medications afterwards. Anything? So usually, one of the questions a patient could ask, are you going to close the wound?
No, we're going to leave it.
No.
Again,
No,
that's
that will
far
allow
from
the
the complete
remaining
answer.
pus to drain out.
Okay. So you have to kind of like explain it to the patient why you're not going to do that as well. But of course, we're not going to close the wound. So what's the two reasons that we usually don't close these wounds?
Speed up
Recollection.
healing and then reinfection the wound.
Prevent the recollection and it speeds up the healing. So those are the two main reasons that we don't close the wounds. We leave these dirty wounds open. So I think that's pretty much of it. So there are a few questions that patients want to ask you during the procedure. So once the procedure is done, what are you going to advise the patient? What's going to happen next?
Change the dressing after 24 hours.
Very good. Do not forget that this dressing needs to be changed after 24 to 48 hours, depending on how bad the wound is. Where do the patient go?
GP.
Go to your local GP.
GP.
Again, depends. If the patient is drained this in theater, the patient usually needs to come back to the hospital. But if the patient is drained usually under local anesthesia, then the patient don't usually need to come back to the hospital. They can just go to the GP, or if they live very far from the hospital. In short, superficial, simple abscesses can be monitored by the GP with the dressing change and then stuff that's okay. You can discharge the patients to the GP. But deep abscesses, complex abscesses, or abscesses that affect the certain areas of the body, like the hands and the feet, axilla, groin, for example, then you have to follow up the patients quite aggressively. So for the purpose of the exam, they usually give you the simple abscesses. So they go to the GP and then get a change. Let's go through these. So one is the change course needs to be changed or removed after 24 to 48 hours, but maximum is 48 hours. Post-procedural advice. So what we're going to give?
Do not shower until 2 to 3 days, and you can bath after around 1
So
week.
shower. When can he or she take shower?
After 2 to 3
After 3
days,
days.
After a few days.
Few days.
After a few days with the application of
A watertight.
waterproof dressing. Very good.
Waterproof.
We will give you waterproof dressing. Don't take shower for the first few days. Afterwards, you can take the shower. When can I take a bath?
Till it heals after
healing of the wound.
After complete healing of the wounds, and it's usually 1 to 2 weeks. What? So bath is the patient immerses themselves in the water, in the bathtub. The shower is showering under the shower. Right? So these are two different things, but we often use interchangeably, but these are two different things. So once you have finished using the shops, they go straight to the shops bin, not at the corner of your sterile area, not into the kidney tray. They go straight to the shops bin. Then afterwards, Bob I'd like to document the procedure and then thanks the patient. So there are a few questions the examiner is going to ask you while you're doing the procedure or once the 6-minute bell rings, depending on the scenario. One is, what are Langer's lines?
The other alignment of collagen lines in the
Dermal
skin.
collagen
Dermal
fibers.
collagen lines.
These are the orientation of the dermal collagen fibers. Right? So your incision should always be along the Langer's line.
Along the line.
And these are the dermal orientation of the dermal collagen fibers. Next is, where would you send the sample? So we briefly talked about it. We're going to send it to
Microbiology lab.
biology. Sometimes we'll have to send it to
special staining,
Histology.
histopathology,
immunohistochemistry, especially when you're worried about
oncology,
Tumor.
like oncology on or
Malignancy.
genetic.
So usually we send it to the microbiology. Sometimes we have to send it to the histopathology as well, especially when you're worried about malignancy changes. Obviously, it really happens with the abscesses, right? But if you're taking samples or doing the debridement or the drainage of other internal cavities, right? Or the ulcers, for example. In the ulcers, we don't, let's say gastric ulcers, we don't usually send it to the microbiology labs anymore. But for the H. pylori, we don't need to culture them anymore. But we still send it to the lab to see if there is any adenocarcinomatous changes or not. So these must go to the microbiology lab, obviously, and to a lesser extent, they might go to the pathology lab as well. Would you close the wound? Is the next question. So as we said, no, because 1, speeds up the healing, 2, prevents collection. Next, the collecting, the packing. Let's say, let's start with the wound problem. So you have closed the wound, the patient goes to the recovery. In the recovery, they notice that there is a lot of exudates coming out. What do you do?
Change the dressing.
The dressing.
One is change the dressing. It might just be a reactionary. And if you change the dressing, it's usually settles down after an hour or 2. Or it continues. What do you do next?
Clean him again, take him to the.
So you keep changing and changing. So it comes to like every hour you end up changing dressings, which is not really feasible. So what do you do?
Put a vacuum dressing.
Corrugate drain.
One of the option is to put a vacuum dressing, but the other option is sometimes there is a super absorbent dressings, especially used with the trauma wounds, for example. Usually in the UK, it's usually the blue coverage from the outside, and there's a super absorbent pad inside. So just put it on and wrap it around tightly, and it will pretty much hold quite a lot of mil inside. So up to 300 to 500 mil of fluids they can hold it without any much of a problem. So you can use super absorbent dressings like that, or if it's getting out of control, then the next step would be vac dressing. What is a vac dressing?
Dressing that's attached to a
acid.
Negative pressure dressing.
Okay, how does it work?
It has a sponge, and you connect it to a negative pressure system, and it keeps sucking the contents.
Right. So let's have a quick look at the picture. For example, this is one of the vac dressings. So what you do is, first of all, it comes with the foam, and this is the system. Right. This is not the vac dressings that we commonly use. Slightly, we use the Johnson's and Johnson's the vac dressing in the UK. So anyway, so this is the vac dressing. So what you do first is that the foam comes with it. So you cut the foam pretty much the same shape of the wound, but slightly larger, because we want to be sticking out. So once we cut it, and then we put the dressing, the black foam into the wound, and then the next cover up with the plastic. So you can see, cover up pretty much everything. The next, you make a small hole here. And then usually it's a cruciate hold, and then you put the top of the dressing put here, and the other end goes and connect it to the machine. And so this is the one. So the wound, the black sponge is put here and then covered up with the plastics, and then you put this and then connect to the machine. This is the canister, which can be changed afterwards as well. What is the pressure that we normally use? Does anyone know? You don't need to know this for the MRCS exam, but just for your knowledge.
125.
That's too high. Right. Usually it's 80.
-20. Yeah.
We start with the 80, usually 80 millimeter mercury, and then goes up to 100. Sometimes it's required 120 millimeter mercury, but usually 80, 90 is more than reasonable. So again, that is the fact. And the pico. When do we use pico? Does anyone know?
No.
What is the pico dressing? Well, pico dressing is the mini vac. What happens is this is already integrated like a vac dressing. So you just peel it off and then put it on, in this case, it's the financial scar, right? And it comes with a mini vac machine. You put the port packet in. This contains a container. This already inside a container which can hold the fluids and also a pump here as well. So this can stay in for how long?
7 days.
For up to 7 days. And this is not a cheap one. You can see this is a small 20 tons, 10 centimeter, which is fairly small dressing, and the cost is about over 200 pounds. So this is not a very cheap dressing, but some believe this is one of the very effective dressing. So when do we use pico?
When you don't want to keep the patient in the
Infected.
hospital.
Well, not necessarily. We do use a pico in the hospitals as well.
Oh,
So what we don't want is the small amount but continuous coming out. So those wounds are ideal for the pico dressing. Because what you don't want is that collection to stay there, or with the dressing soaked with that fluids, and that fluid stays in that for the next 24 to 48 hours. With the pico, that fluid is continuously sucked out. So that small amount of fluids will continuously be sucked out, and in theory, that enhances the wound healing. So pico is usually used for the wounds with small amount of exudates that continuously coming out. So small amount, why? Because the pico container is very small. I think it can only hold about 120, 130 mil in total. So for the next 7 days, what you expect is maximum 120, 130 mil. And all of these, most of the things, the exudates, one, they are getting sucked while they get kind of like semi-clotted and stuff. So they don't always fill up the container that quickly. And if the container is filling up quickly, or if the exudate's too much, then you shouldn't be using pico in the first place anyway. So this pico is kind of like a mini vac, which is best fitted for small exudates wounds. So are you going to give antibiotics for this patient, by the way?
No.
it is small and completely
This is an abscess.
drained. It is complete.
No,
If it is
if
completely
it's
plain and small one, then we don't need to give antibiotic, except is there any cellulitis and
Very good. So
cancer.
adequately drained abscesses do not need additional antibiotic therapy unless the patient's immunocompromised or the patient's got uncontrolled diabetes or insulin-dependent diabetes, or there is other obvious infections like cellulitis, surrounding cellulitis with the abscesses. Properly and adequately drained abscesses do not really require antibiotics therapy. Well, keep that in mind. So let's quickly recap these things. So incision should be along the Langus line. Langus lines are the orientation of the dermal collagen fibers. Why the wound should be left open, one is to speed up healing and subsequent infections or recollection to decrease it. Wound packing, can start packing the sterile gauze or the ribbon gauze. Iodoform gauze, we don't usually do that anymore. Why?
it's an irritant.
Skin irritation. Irritation.
Because of the irritations of the skin, and there is not much of a change in the outcome.
Coloration.
So that's why iodine is not usually used. The iodoform gauze or the gauze soaked in the iodine is not used to pack the wounds anymore. And most commonly, we use the Aquacel, silver-containing hydrofibers. And then the wound dressings, we can use the Mepo or the Softball. These are the island dressings with the pad in the middle, or more absorbent dressings like Aquasol, Alternates, or the Eclipse. So these are integrated ones, slightly thicker ones. And lastly, if there are excessive exudates, if it's a small amount but continuous coming out, then Pico, or if it's a large wound, deep wound, then you should think about the fat dressing. Any questions?